This conference will now be recorded. This conference will now be recorded.
So, welcome people. So today's class is all about discussion. What are the changes in the new guideline of outpatient hysteroscopy? Apart from this, there is a Viva station and small discussion about the hysteroscopic procedure. That would be important. They come. I'll be giving the debrief because usually when the pre-op round comes in part three stations, then they give the scenario. Okay. So, like first, I'll be starting with the guideline only. So, what they want, what is effective for the patient hysteroscopy? So, usually there should be a dedicated outpatient hysteroscopic service, so that women coming with the abnormal uterine bleeding, reproductive problems, insertion or and removal of intrauterine devices or IUDs. So what they want, that OPD hysteroscopy should be done in a outside the formal theater. Apart from this, there should be a dedicated a facility with all for this hysteroscopy. This is just an requirement for the hysteroscopic services. So when the patient comes for output hysteroscopy, what the guideline recommends, the patient should be provided with a written information that would tell them about the details of procedure, benefits, risk, analgesia, and the alternative options to the patient. Apart from this, patient should be made aware that what are the other settings and what are the modes of anesthesia. Either it is general, regional, and IV sedation. Apart from this, as OPD hysteroscopy usually they are giving that anesthesia only. So this procedure could be made more painful and difficult, traumatic for the woman having following histories, like if they have got crampy pain or fainting during a menstrual period, if they have period or anxiety, severe pain or anxiety when they go for vaginal examination and going for cervical smears, or any traumatic experience, sexual assault or something like that. So these are the few things, though we know them, but this has been added new in the guideline. It was not there previously. So possibly the part 2 people can get this kind of question from here, that which woman, for which woman the outpatient procedure is going to be painful. Now, before OPD hysteroscopy, consent has to be taken. That is taken for everything, every procedure. Informed consent has to be taken. And because it is done only under, yeah, they are usually given analgesia. So they should be assured that if it isn't painful, then the procedure can be stopped in between. And if they have a sometime, when the cervical, when the scope goes through cervix, so sometime at the time of dilatation there could be the vasovagal. Okay. So if that happens, so there could be possibility, procedure has to be stopped, and appropriate management for vasovagal attack, episode has to be done. Now, what are the checklist? So this checklist has been introduced this time only. Previously, it was not there. So, what are the checklist? The patient should have a confirmation of identification, name, date of birth, and address. There should be discussion of all settings in the pain management, IV sedation, regional or general anesthesia, or in a daycare settings, consent, allergy status. Very important that everyone should be aware of, that the urine, if the patient is of reproductive age, and then it is important before you take the patient for hysteroscopy, a urine pregnancy test has to should be done. Ideally the pregnancy has to be ruled out. So this would be important. And you can, part 2 people can get a question, and part 3 people, when you are getting pre-op case list, and if you get like you're sending a patient for hysteroscopy or anything, you have to say that I would like to rule out pregnancy test, uh, making sure the patient is not pregnant, because that will give going to give you marks on the safety. Because of that, I have highlighted this point. Now here there are certain some changes are there from the previous guideline. In previous guideline, with regards to analgesia, they used to give oral NSAID 1 hour before, that we know from the old guideline. But now in this guideline, few more things they have added. What are they? Like if any woman has got contraindication for NSAID, for example, if they're asthmatic, if they have renal impairment or gastric ulceration, in that situation use of other like analgesia can be done. For example, tense machine, lactate nerve stimulation, or oral opioid, or antispasmodics, or like these the options are there. Apart from this, um, like inhaled nitrous is also an option, gas and air. And the content of that you already know from your obstetrics. It is 50% nitrous and 50% oxygen. Okay. Another thing that they have added is penthrox, that can also be considered reduction of pain in OPD hysteroscopy. So all the like tense, use of oral opioids, antispasmodics, and use of gas and air, and penthrox. All these are new added, these analgesia forms in this guideline. They were not present in the previous one. Okay. Now this is a you already know what is a tense machine. So this is a tense machine, like some electrodes are put, and usually the patient will feel vibration, and this is the mechanism for the pain relief. It is used in the laboring mothers also. We offer that as an option. Another thing that the guideline has offered is like penthrox. What is penthrox? Penthrox is an anesthetic agent that can be self administered by a handheld inhaler, currently used for moderate to severe trauma associated pain in emergency setting. And you can see the picture of penthrox. Okay. So these are the few new pain relief option that the guide has been added in this guideline. Now, coming to the cervical preparation, as we already know that cervical preparation is not done routinely, but if it is required, usually prostaglandins are given, and that is given 12 hours before. So, like part two people may get question from there, that they like how when the prostaglandins has to be inserted, that is like night before or 12 hours before. Now, cervical preparation to be done in which cases where they're suspecting possibility of difficult entry, such as cervical stenosis, and like if they have to do dilate the cervix more than 6 mm. It's like some uterine instrumentation is required. That time, it won't be able like that time they have to dilate, and before dilatation they would require to give vaginal prostaglandins 12 hours before. Vaginal uh, yeah, class is on, Shweta. Prostaglandin, like when the prostaglandins are given, there would be reduced pain. There could be possibility, spotting or bleeding or gastrointestinal side effects. That we, whenever we give all this, mesoprost to the patient, sometimes the patient would have bleeding. That time entry to cervix become difficult. And but risk, what the guideline says, risk of failure and complications such as cervical trauma and uterine perforation will not be reduced even if the cervical preparation is done. Now, what they recommend for outpatient hysteroscopy, ideally the small diameter outer sheath has to be small in diameter for the diagnostic output hysteroscopy. Like their recommendation is 3.5 mm or less in outer sheath. So you can see the picture. So this is the scope, hysteroscope, diagnostic hysteroscope with 3.5 mm of outer sheath. That means the whole diameter. Because you and but you will find like even lesser than that is available in the market. That is 2.9 mm scope is also there. So you can see that, is it is very small, so it can be easily introduced, negotiated through the cervix. Apart from this, what they say, when the operative hysteroscopy is done, smallest diameter hysteroscope to be used with a consideration that expandable outer channel. Because when you are going inside the cervix, then the diameter is small, but they can expand inside, so that would cause less pain. Apart from this, whenever, if they want to do any like polyp removal or anything, so it has to be, they want them to use mechanical um, removal system. And I will tell you how the mechanical like the hysteroscopic removal system works. So that means they don't want to use energy, because we understand it is being done in the OPD, and also the patient is only given analgesia. Now, choice of the hysteroscope. So hysteroscope could be rigid, and this hysteroscope could be flexible. From the picture you can find out what is a rigid hysteroscope and what is a flexible one. Now, the choice will depend upon the facility and the expertise who are doing it. Mostly we are you in use the rigid hysteroscope is done. What is the benefit of it? There would be better image, less chance of failed procedure, because entry to the cervix become easy only with because it is a straight one, quicker examination and reduced cost. So this is the flexible, you can see, with a flexible chances of less pain, and but yeah, more times the procedure may be failing. Okay, so this is the two types of hysteroscope. Now, what they want, mechanical tissue removal over bipolar electrodes. So these are, you can see, these are the biopsy forceps, these are the Caesar, this is again the biopsy forceps. So usually in the OPD hysteroscopy, if they find any polyp or anything, they want to, instead of using any current, they recommend to use mechanical instrument. Okay, for taking biopsy, for removing polyp. Okay, so these are the mechanical methods. And these are the they prefer inactivated mini Caesar as compared to bipolar electrodes, because it is being done in OPD basis. So the recommendation is to use mechanical instrument rather than energy source resources. Apart from this, coming to the distinction medium, what is the recommendation of the guideline? It is to use normal saline. Okay, most commonly these days we are using the normal saline only. Now they recommend that it should be warm saline, approximate to the body temperature. Okay. Now, usually it can be done mechanically, or like automated fluid management systems are there. These are the Histromat. So with that, the when the fluid is getting put inside, so even like they can do the measurement easily. That becomes easy. Apart from this, the guideline says that the for diagnostic, or when they are doing it in OPD, so intrauterine pressure of 40 to 50 mmHg is enough. Okay, so this is a recommendation by the guideline, that 40 to 50 millimeter of mercury intrauterine pressure, initial pressure, when you are getting to get a uterine cavity satisfactory view. Okay, because whenever the diagnostic or usually hysteroscopy is done, the recommendation is to keep pressure less only, but at the time of operative it has to be increased. But we have to take care of that, because more increase in the pressure, more chances of fluid getting absorbed. Okay, now about the like same thing, they have saying it again. So routine dilatation is not done. Local anesthesia also routinely not given, and local anesthesia can be considered if cervical dilatation is anticipated because of the cervical stenosis, or larger diameter hysteroscopes are required. Apart from this, why they are saying no to like local anesthesia? Because instead of putting speculum or servolculum to hold cervix, that causes pain to the patient, so they recommend to use vaginoscopic technique. In vaginoscopic technique, what really is done? So speculum is not put, and neither the cervix is hold with a that uh, with a tenaculum or whatever. So that what is in the vaginoscopic technique? Usually, a vagina will be filled with the saline, and then in the direct vision they will look for the cervical os, and they from the vagina the scope directly will go into cervix, and then from cervix it will be further proceeded further, then it will reach into the uterine cavity. Okay, so this is the vaginoscopic technique when the vagina is filled with the water, like with a saline, and under the direct vision they will go to the cervix. So not holding cervix with any instrument, not putting any speculum. So this is the vaginoscopic technique. And if they are using vaginoscopic technique, and if they are using lesser size hysteroscope, you can understand that there would be very less pain. Okay, these are the things they are recommended, so the pain in outpatient hysteroscopy is less. Now this is also added new in the guideline. It was not given all this anesthesia thing before. So what local anesthesia to be administered, and how it should be given if it is required, like consideration for MVP, mepivacaine and bupivacaine. So they say that two agents are associated with less pain in the OPD hysteroscopy, and maybe maybe mepivacaine is the only agent that usually decreases the vasovagal episodes. Now, choice of anesthesia, whatever has to be given, decided by the by the person who is doing that. But short-acting local anesthetic like mepivacaine, lidocaine, prilocaine, they are short-acting. Usually, it required to be wait at least for 2 minutes after it is given. And locker bupivacaine is the longer acting. It will require to wait at least 5 minutes before the effect comes. Okay, so this update about local anesthetic, what to be given, and which is the longer acting and shorter acting, it was not given in the previous guideline. It has been added here in this new guideline only. So for part 2 people it becomes very important. For part 3 people, knowing so much details is not required. Then conscious sedation, ideally they don't recommend, but if it is given, then it should be histoscopy done in a place where a separate staff member to be there, who has got appropriate skill and equipment if it is required to observe the patient, recognize and care the woman if they are over sedated. So conscious sedation ideally not to be given. If it is being done, there should be monitoring of the patient and to take care whether they are over sedated. This part I have already explained. They recommend vaginoscopic entry. So, vaginoscopic entry should be considered unless there is a it should be OPD unless there is a use of speculum is required. Uh, Even if they have used speculum for anesthesia, for dilatation, even after that, they recommend to go for vaginoscopic entry technique only. Now, prevention of infection. This is also added new in the guideline. So, routine antibiotics are not recommended for outpatient hysteroscopy. But if they suspect the patient is having infection, either they will take swab or they will give antibiotics. Apart from this, if the biometra is there, antibiotic should be given because otherwise there would be spread and there would be systemic infection. So this is all about the infection that the guideline says. Okay, so in the guideline only this much is there. Now I have put some viva question. Anyone wants to attempt it? There are four questions about the hysteroscope. Anyone part 3 person who want to attempt?
Can I do it, doctor?
Yes. Okay. The question, like it is a basically I have to teach, but it's a small question that I have put. The woman, 39-year-old woman, going with the complaints of irregular bleeding has been posted for hysteroscopy. Now there are series of questions. So these are the questions for you. What are the types of hysteroscopy? What are the indication for it? How would you do hysteroscopy? What could be the complication at the time of hysteroscopy? So you can just
Yeah,
answer.
I need to write this here.
Huh?
Can I see the previous slide? Just the previous slide, so I will write in my handwriting. Previous slide.
Like basically, it is the hysteroscopy virus scenario is just I added, but
Yeah.
scenario makes no sense. Yeah.
Okay. That's, can I see the second, please?
Mhm.
So, so type of hysteroscopes, we have a different type of hysteroscopes, either an flexible hysteroscopes or rigid hysteroscope. There is also a type of outpatient and inpatient hysteroscope, and also there is different diameter of hysteroscope and with different type of lenses. Um, this is and there I also we have operative and we have diagnostic hysteroscope,
Yes.
not only
Okay.
operative. Yeah.
So, what are the indications for hysteroscopy?
Usual indication, there is common indication for hysteroscopes, like if we have any irregular vaginal bleeding, like postmenopausal bleeding, and irregular vaginal bleeding for premenopause. Also, if we have, usually it's most commonly bleeding. Also, if we have some cases like missed IUCD implanted inside the uterus could be used. Also, we can use it in case of recurrent miscarriage, second trimester miscarriage, or preterm labor could be used. Also, we can could be used after when we have sub cases of subfertility. We can use some of them. They use it before IVF hysteroscope just to check the endometrial cavity. Uh, and but most likely it is vaginal bleeding when we have postmenopausal and perimenopausal vaginal bleeding, especially when there is a suspicion of malignancy or non-malignant conditions, like in case we suspected some endometrial pathology or like in form of polyp, hyperplasia, malignancy, or whatever causes. Also, it could be hysteroscopes used in case of like in have septum, suspicion of uterine have septum, could be for diagnostic and therapeutic also. And when we have submucous fibroid, it could be also used in case of Asherman syndromes for as a diagnosis and treatment for Asherman syndromes with the possibility. Usually, this is inpatient hysteroscope. According, mostly an outpatient hysteroscope for diagnostic, what could be probably for certain therapeutic, but therapeutic, if it's take times or more, it will be inpatient. Also, um, hysteroscope before it was used for as hysteroscope issue for bilateral tubal occlusion. I think now it's abandoned in UK.
Yes. So, Ashore has been removed from the by the government in 2017. So, you should not speak about the Ashore.
Oh, okay. Yeah.
Yeah, very nice. Now, how would you do hysteroscopy?
Suppose if it's outpatient hysteroscope, there is usually there is a written consent and discuss the patient pros and cons. If there is other than hysteroscope, like if we need, sometimes we can do pupil biopsy for certain bleeding, but otherwise, if we patient decide for hysteroscope, there is as I mentioned, consent. There is written consent, pros and cons, and also the preparation pre-op, like according to the difficulty we expected, or according to the pain threshold for the patient. It could be we have a certain measure we can to reduce the complication and risk of hysteroscope. Like we can prepare the cervix. It could be by prostaglandin if we expected that it will be cervical stenosis, like in postmenopausal, or in case patient with a previous surgery for the cervix, like cone biopsy or lids recurrent. There is we expect the stenosis, or nullipara patient and also there is possible we need analgesia according if non-steroidal anti-inflammatory oral we can give it 1 hour unless it's contraindicated or allergy. So now there is possibility we can give oral narcotic, or could be TENS if there is facility, or there is nitrous oxide according to the facility. However, sedative I mean conscious sedation is not a preferable method of pain relief. And also we can reduce the pain by rather than using speculums and teneculum, we can use vaginoscope approach. And also there is possibility you can use flexible type of hysteroscope. However, there are some obstacles with the flexible hysteroscope. Maybe go with the rigid type of hysteroscope. After patient consent, WHO checklist, then we can go for hysteroscope in an outpatient procedure. Usually there is a light source and there is camera and direct vision, and also there is a fluid input and output. There is different I mean to open the uterine cavity we have different way, either CO2. I think CO2 now is restricted use because it's not a clear view, but we have normal saline use or glycine. And I forget normal saline. Normal saline may be used with certain type of electrocautery if they need, because it's power of connection, but I forget really which type. And we have glycine. And according, there is input and output for fluid to check to reduce the complications of fluid overload.
Okay, what could be the complications for hysteroscopy?
So scopes could be immediate complication and late. It's like if suppose it may be bleeding, sending infection. It could be lead to cervical difficulty to and for I mean failure of hysteroscope introduction. It could be false pathway. It could lead to the perforation, or it could lead to fluid overload. I forget the term so used for fluid overload with hysteroscopes. Yeah.
Okay.
If GA we use GA, it's a complication of GA, but if you use non-GA, that's another issue.
Yeah. Okay. Very nice. Good presentation, but a little more organization is required. So I'll now tell you. So for part three, people hysteroscope how it can come. It can come as a Viva station that examiner will show you hysteroscope, and you have to kind of describe the instrument, and then they ask couple of questions. So these kind of questions you may get, or it can come in the exam as a teaching station. So two ways hysteroscope can come. Okay, so you have to have a brief idea about that. So now what are the types of hysteroscopy? Basically, I was asking type of hysteroscopy, but you described the hysteroscope as well. So I was just asking what are the types of hysteroscopy. So there are two types. It could be diagnostic or it could be operative. Okay. Now, second question I asked, what are the indications for hysteroscopy? You answered it very well, but you can split the answer in two parts: indication for diagnostic hysteroscopy and indication for operative hysteroscopy. This way of answer, it looks more organized, isn't it? So, indication for diagnostic hysteroscopy, like at least in the exam, you if it comes, you have to minimum 4 to 5 at least you should speak. So what are the indication for diagnostic one? Abnormal periods less than 45 years, AUB, HMB, postcoital bleed when the smear is normal. We need to look inside what is there. If history suggests of endometrial pathology, fibroid polyp, such as the patient comes with intramenstrual bleeding or irregular bleeding, or infrequent heavy bleeding in the patient who is obese, on taking tamoxifen or any medical treatment for HMV has become unsuccessful. Another is the postmenopausal bleeding. Usually, when there is a bleeding, recurrent bleeding, and scan shows it is more than 4 mm, and like people is not possible or cannot be done. Abnormal pelvic ultrasound findings, which you find polyp or some mucous fibroids, then if you kind of want to confirm it. Subfertility, some of the cases it is done, as you rightly said, it is done for the subfertility before. Usually even the IVF is done. The people do cavity check before placing the embryo. Recurrent miscarriage, yes, you were very right. We need to diagnose if there is a septum is there, or whether it is also necessary when the ultrasound shows the picture of Asherman syndrome or any congenital anomaly. So these would be the indications for diagnostic. So at least five six indication kind of you should know, in an organized manner. You have to tell it to the examiner. Then second part of the question, indication for the operative hysteroscopy. So this is like a simple one only. So consideration for to diagnose and remove polyp and the fibroid. Then um, if the such as a trans cervical resection of endometrium or TCRE is done. Usually it is done in cases of ablation. Other methods of endometrial ablation can also be done with that. Polyp can be removed, biopsies can be taken, myomectomy can be done, and metroplasty or division of uterine septum can be done. Adhesolysis or for the Asherman syndrome can be done. Removal of copper T or any foreign body can be done. Usually it is a misplaced intrauterine device. Sometimes it can be there for the selfingography. So this could be the operative, whatever you are diagnosing, the treating them would be the operative hysteroscopy. So same thing, just put the answer in two headings, then it becomes more organized.
Yes.
Then third, okay, so you should also know what are the contraindications. If the patient is having pelvic infection and the pregnancy, usually you can understand the hysteroscopy is not done. Now how to do the hysteroscopy? So you should know that. So because if they give you hysteroscope, they will ask this to teach, or they can ask you to say tell me how you would use it. And when you are speaking to examiner, if the instrument is given, you have to kind of actually show how you are doing it. So that part I cannot show here because it is an online. And so how it is done? So what are the usually the instruments? You would require hysteroscope with a diagnostic sheath, either with a single flow or continuous flow. There would be a light source in the cable, camera system, and distension medium. Usually there are many kind of distension medias, but there are two distension media that is used regularly. One is a normal saline. Normal saline is always used. For the diagnostic it would be normal saline only. Now other is normal saline is isotonic to the body, so that is the isotonic media. Another one is a glycine 1.5%. That is a like that is hypotonic to the body, and usually glycine is used when operative hysteroscopy is done. And in operative hysteroscopy, monopolar cautery is used. If it is bipolar cautery is used, then it would be normal saline. So mostly in diagnostic it would be normal saline only. So first the prepare so these are the instrument for hysteroscopy. Now the preparation for hysteroscopy: clinical assessment, bimanual examination to assess the uterine position, shape, size, volume. Yeah, we need to rule out pregnancy and informed consent. Apart from this, ideally in the reproductive age woman, it should be done in a post-menstrual phase because the endometrium is thin, so diagnosis become easy. Okay, so after all this, now a patient would be either given analgesia, put in a lithotomy position, and ideally the like the patient's buttock should be at the edge of the operating table because we have to maneuver the hysteroscope during procedure. Now usually the you, many of gynecologists can use speculum to grasp antenaculum for the cervix, but usually the guideline recommends that is a no touch technique or the vaginoscopic approach to be used with when they enter the uterine cavity. Usually the hysteroscope is proceeded towards fundus with adequate distension. Now usually the tip of hysteroscope is placed one like 1 to 1.5 centimeter away from the fundus. Why? Because we have to see the ostia, then they can move the they can see the whole cavity, anterior wall, posterior wall of uterus, lateral wall of the uterus, and they can see both ostia and by moving the light cable. Okay, this is just, this would be the theoretical part. But yeah, if they give you instrument, then you have to speak and you have to explain with the instrument. Then when the all cavity is seen, then gradually it is withdrawn into the cervix. That time, like a panoramic view of the whole of the uterine cavity and the endocervical canal can be obtained. Okay, so this is the procedure for hysteroscopy. This is the way hysteroscopy is done. So I what I was speaking, it was about the diagnostic hysteroscopy. If they ask you how to do the diagnostic hysteroscopy, it or it can come as a teaching station also. Now another question I asked, what could be the complication for diagnostic hysteroscopy? Mostly you said fine only, but yeah, so what could be the complications for diagnostic hysteroscopy? Failed procedure, less than 2% of the cases. Why it fails? Sometime, it is a cervical stenosis, you can't enter. Sometimes false passage is created. Okay, there could be problem with the distension media, though they are very rare in diagnostic hysteroscopy because we are using normal saline and we are using it for very small time. And as any procedure we are not doing, so possibility of absorption becomes less. Then the problem could be with the procedure, infection, bleeding, cervical laceration, or uterine perforation. Apart from this, there could be anesthetic problems. So these would be the complications for pain. The that part we already know, that there should be appropriate case selection and consideration for NICID to be given beforehand, 1 hour before, and the pressure has to be 40 to 50 mmHg as recommended by the guideline. There could be complication to the anesthetic, like when the LA is given, sometime it can be injected to the vessel, or there could be vasovagal. So these are the complications you can enumerate for the diagnostic hysteroscopy. The complication for operative hysteroscopy, it could be like early or immediate, or it could be late. Immediate, yes, it could be uterine perforation. There could be fluid overload. Operative hysteroscopy, as the like operative thing is done, so vascular channels are open and it takes longer time. Possibility of fluid overload will be there. Then there could be bleeding, there could be infection, cervical trauma, air embolism can also happen, and there could be issues with the cautery. Okay, bun. Late complication, there could be intrauterine adhesions, hematometra, pyometra. In electro after endometrial ablation, there could be post ablation syndrome. And also, if a patient becomes pregnant after endometrial ablation, there could be pregnancy complications. Apart from so these are the complications from operative hysteroscopy. Now a few things about the fluid overload. So fluid overload, or fluid deficit, In case of hypotonic saline, if the fluid deficit is more than 1000 ml, and in case of isotonic saline or like normal saline, 2.5 2500 ml, if the deficit in the fluid is there, then it will be fluid overload. This definition of the fluid overload is from the hysteroscopy talk that came in 2018. And fluid overload will depend usually what type of procedure we are doing, and what type of media we are using, and how much the pressure is created. Now, how to manage fluid deficit during operative hysteroscopy? So usually if it is less than 100, they can continue with the surgery. 500, continue with the surgery. If it is up to 1000, then expedition of the procedure would be required. If it is like 1500 ml, the patient has to be uh, procedure to be expedited. Electrolytes has to be done, patient has to be catheterized, furosemide to be given. If it is more than 2.5 liter, furosemide given, and the procedure has to be terminated. Okay, so though it is very small thing that you should know, no, usually it is not asked in the exam, but yeah, good idea. That was a good table given in the OGRM article, so I put it. So this is all about the viva. So basically these kind of question can be asked in the viva if they give you any instrument, or these type of same thing can come as a teaching task also. So usually people find to prepare hysteroscopy viva or task difficult because it is not given anywhere. Because of that, I just created a small station. Now something about the hysteroscopic procedure I had to say, and the instrument, because that would be necessary. So now it is the see, it is a diagnostic hysteroscope. Diagnostic hysteroscope, and now this is the outer sheath, and this is the inflow. That means the fluid or normal saline will be flowing from there, and this is the camera. This is, here the light cable will be attached, and this is the like camera. Okay, so here only one channel is there, because you're putting water like saline for small time, so that the uterine cavity can be distended. So this is diagnostic hysteroscope. So this part I have already explained. So this number one, this is the video camera. Number two, this is the light cable. Number three, this is the hysteroscopic sheath. This is the sheath, and this is the irrigation fluid system, like for the fluid. Now operative hysteroscope, this you should also know. Now you see there is a working channel. So this is a working channel, people. This is the port for the camera. This is the port for the camera, and this is the working channel. And this is this is inflow. From here the saline will come, and this is outflow, because if you are doing any procedure, there would be bleeding inside the uterine cavity. So blood mixed fluid has to come out, otherwise your field will become hazy. So you can see in the outer sheath here some holes will be there. They help the water to come out through this outflow channel. Outflow channel. So this is inflow channel, this is outflow channel, this is working element, working element, and this is the camera. And from this working element, usually these instruments, these are these are the rigid instrument, but the flexible instruments are there. They would be put from here, for example caesar for polyp, or there could be endometrial biopsy forceps. Now this is the again the same operative hysteroscope. Now you can see that from the working channel, this is the working channel. Now you can see one of the flexible instrument, it is already going there. So this instrument here tip will go to take biopsy, or if it is seizure, then they do polypectomy from here. So this is the operative hysteroscope. Okay, this is the differences. Now this is a resectoscope. Usually resectoscope is used for TCRE, transcervical resection of endometrium, or for the fibroid hysteroscopic fibroids when has to be removed. they also has to be the similar kind of instrument is used. Now when this kind of instrument is used, your surgery is being done, that time uh, there is vascular channel will open because your endometrium is getting resected. That time more chances of fluid overload is there. So what for that, there should be a automated system for the fluid, that is like histromat. Apart from this, there should be a dedicated person on the floor who will be doing the input and output calculation, so that you know immediate calculation for fluid deficit can be done. So this is very important, mostly when they are using a resectoscope, or when they are doing like this operative procedure. So here you will find like it is a so this is the kind of instrument. So now here there would be at the tip you will find three like holes. One will be for camera, one will be for your working element, another will be for your cautery. Now can you see this is the working element? So can you see this tip? Usually the electricity is attached, and with this the tissue usually comes out in chips. Okay, so this is resectoscope. A little bit knowing about the resectoscope is enough, because in the exam nobody is going to give you in resectoscope. It is a very delicate instrument. Now few things about the procedures you should know. Why? Because they give you in pre-operative round, and if you have a small idea about the procedure, then you will not going to make mistake. Otherwise people says irrelevant thing in the answers. So this is the endometrial polyps. So this can, you can see the polyp here. It can be used with a flexible instrument or the mechanical instruments, or it can be used it can be like removed using cautery also. Using cautery, like it is cautery and this is also the cautery, they can be used. So there it can be, as I said, it can be done with the mechanical instrument like biopsy, forceps, Caesar, or it can be done with electrosurgery. There could be any kind of electrode could be there. Versa point is also a bipolar electrode or the twizzle. So much details are not required, but a just brief idea that how polypectomy can be done. Another thing that comes is the hysteroscopic myomectomy. So hysteroscopic myomectomy can be done using resectoscope, electrocautery. It can be done using versa point, or it can be done using myosure. So you should know about the myosure and the resectoscope, because these two things usually asked in the question. So I've this is the hysteroscopic myomectomy. So usually now it is done with the this thing resectoscope only. This is a resectoscope, and this is the electric cautery. Now you can see the tip of electric cautery. Usually the electric current will be used, and with this in small pieces the fibroid will be shaved off. Now this is, you can see this is fibroid. This is the myomectomy is being done in between, and here almost they are reaching towards the end only. So in small pieces the fibroid is usually removed. Okay, so the basically they in the your pre-op checklist they give the patient is for hysteroscopic myomectomy. So now you should know, because you have to arrange that, so you should know what type of instrument you are using and what could be the complication and what you should be aware of. So instrument you are used is a resectoscope, and the most common complication that we should be aware of could be the like fluid or overload. So there should be a dedicated person for that. Apart from this the person who is doing that should be aware of the hysteroscopic all settings. And if they are using hysteroscope with the monopolar cautery, the distension medium will be glycine, and if it is with the bipolar, then the distension medium will be normal saline. Only small this much things would be like brief small thing is required, because they are going not going to ask you about the procedure. Usually it comes as one of the patient in the pre-op checklist. So the small idea about the procedure has to be there. Another is the hysteroscopic morcellation. One time in the exam, even morcellation was asked. So now, what is the difference, people? So see this, the morcellation. Now you can see the tip. You can see the tip. Now with they will put attach it to the electricity or current, then like small pieces, this like this they will be this they will be removing it. So good thing, what is the difference, what is the good thing about this is the myosure. Okay, my myosure also, one time they asked in the exam, only small question was there. So this is the myosure. Okay, now what is the difference and benefits of this is the in hysteroscopic myomectomy, we are using current. So when we are using current, we can go deep also. So there could be uterine wall damage or uterine perforation. Now you see this instrument, this is the hysteroscopic myosure. So here, like within bits and small pieces, like a grains, small grain, the whole fibroid will be gone. And this, with this tip, it will be attached here only, and it cannot perforate or damage the uterine wall. Once the whole fibroid will be removed, then you will not be able to do any damage. And it is mechanical, so electrical damage cannot happen. But yeah, you have to be worried for the fluid overload in this also, because this is again a hysteroscopic technique. So why I have put that, because in your pre-op checklist sometime you get the patient for myomectomy with the marcellation with the myosure. Sometime you will get the hysteroscopic myomectomy, and the people, they have no clear idea, and they can't post the right thing in the answer. So I used to teach in the course, but now I have put it here, so that you should have a clear idea what is the difference. Though it is a very small difference, but when you are answering, if you say something like not irrelevant, examiner would know that you have got no idea. So it is important. Apart from this endometrial ablation, uh, sometime one time the endometrial ablation also asked. So the indications for endometrial ablation: the patient having heavy periods less than 45, and the medical treatment not working. What are the contraindication? It is important to know: large uterus less than 12 weeks, and large submucous fibroid, any cancer, infection. And when the patient doesn't want to preserve fertility, usually if the patient is for endometrial ablation, then for like patients fertility has to be complete, because after that if she gets pregnant, there could be possibility of for all placental complication, accreta and all. Okay, so this way the endometrial ablation is done, with the resectoscope, that is a transcervical resection of endometrium, TCRE. Though there are other methods for the ablation is also there, like a hot balloon and microwave, so many other types. I will not speak about that, but this you should aware of that, because sometimes they ask that in the they give this as one of the case in the pre-op checklist. Okay, so in the similar way the myomectomy is done, same way the endometrium would be, like long pieces, bit by bit the endometrium will be shaved off like this. So they will do like that. This is the endometrium normal. This is in between the procedure, and this when they are mostly they have removed it. Okay, so these are the complications for TCRE: infection, hemorrhage, hematometra, and post ablation syndrome, cyclical pain. They have not asked this, but yeah, just to complete the topic I have said. Late complication, there could be recurrence, there could be pregnancy, and if pregnancy happen, there could be placental complications in the IUGR. Rarely when the possibility of malignancy. Why? Because when the TCRE procedure is done, they would remove endometrium, but around the ostia, around the cornu, around the ostia or the corn of the tube, or the cornu of the uterus, usually this probe will not go, and the redundant endometrium usually stays there. Because of that, some of the cases cancer may happen. That's all I had to say about the TCRE. Now, this is a hysteroscopic metroplasty, that is a septum resection. Okay, now usually they use an instrument. So this instrument you can see, this is a name of the instrument is a Collins knife. They use current, and they like, for example, it has been started from here, and they kind of cut the septum like that to create a cavity. So just know a little bit knowledge about this would be necessary, because though this time on the uterine septum the viva has come, but it is nothing to be related with the procedure. But the people were not, forget the name that time. So this is a hysteroscopic metroplasty. That's all I had to say. So I try to cover the guideline and what are the important point relevant to the hysteroscopy necessary for to know the part 3 people. That's all. Thanks for joining. Any one of you have got
Thank
any
you.
question, you can ask me. Any question, people?
Thank you very much, ma'am.
Okay, bye, people.
Excellent question.
Accept that.
Thank you, ma'am. Thank you, ma'am.